we come to certain complications. We've discussed the main symptom. Now we come to the exocrine pancreatic insufficiency. Now adults, they're already beyond their second, third decade, of course more than 18 years. So if they have had a pancreatitis early in their childhood, they have already reached a stage when the pancreatic functions have started deteriorating. So there is a time which comes when the exocrine function of the pancreas starts getting affected. This happens because pancreatic lipase formation is impaired. This lipase output decreases more significantly as compared to trypsin or amylase. That's the reason whenever we are replacing enzymes in these patients with pancreatitis, we always look at what is the quantity of lipase in that particular medication rather than anything else. This lipase is also more sensitive to acid destruction than other enzymes. So it is less produced in chronic pancreatitis. It's more vulnerable to the gastric pH or a low pH. So now this exocrine pancreatic insufficiency happens when the enzymes are almost 5 to 10% of the original reserve. That is, a more than 90% destruction of the exocrine function of the pancreas leads to an exocrine pancreatic insufficiency. Now, when there is absence of the pancreatic enzymes, there is a decrease in duodenal pH. Why? Because pancreas secrete bicarbonate. This secretion is impaired. So now there is precipitation of bile salts because the pH is acidic. There is impaired formation of micelles while digesting the fats or triglycerides, and hence there is fat malabsorption, which leads to steatorrhea. Now, steatorrhea, how do you recognize it clinically? You ask any parent, they will say, my child's stools are sticky. Stools are supposed to be sticky. But do they notice a layer of oil, visible oil around the stools? That's steatorrhea. Is there a bulky stools? Stools are always offensive and malodorous. You can't expect good odor from stools. But are they bulky, large volume? Do they have oil around it? Is it hard to flush? These are the things which we need to see. What are the major symptoms? There is failure to gain weight because there is impaired digestion of fat, impaired digestion of proteins, and because there is impaired absorption, the appetite sometimes increases. That's ironical increase in appetite which happens because of exocrine pancreatic insufficiency. Now, the most worrisome consequence is fat is not digested, so there is a fat soluble vitamin deficiency. So ADEK is significantly impaired absorption. You get all clear symptoms, and most importantly, those of vitamin D and vitamin E are worrisome. What is the median time to develop this steatorrhea? So if we look at the early onset idiopathic pancreatitis, which is in children, it takes nearly 25 years, which is a median time. It can happen at a greater time interval, but the median time is say about 26 years when steatorrhea happens. But there are certain conditions where the exocrine pancreatic insufficiency happens far earlier also. For example, late onset idiopathic pancreatitis, or in adults, alcohol associated pancreatitis. But eventually, as a rule, 50 to 80% of patients with chronic pancreatitis develop EPI. Now, if somebody asks us, especially in the era of multiple choice questions, what is the most common cause of exocrine pancreatic insufficiency in children? Then it's not chronic pancreatitis, it's cystic fibrosis. In adults, it's chronic pancreatitis. Now, then comes the million-dollar question, does cystic fibrosis not cause chronic pancreatitis? So that's a dilemma. So cystic fibrosis causes pancreatic insufficiency much more than chronic pancreatitis, despite the fact that there is a gene called CFTR which is implicated in chronic pancreatitis. This particular gene is more for pancreatic insufficiency, and an impaired CFTR can cause chronic pancreatitis, but less often than pancreatic insufficiency in cystic fibrosis. Now, the way to estimate or to assess EPI is to measure either the stool tests or certain other tests for pancreatic insufficiency. How to treat it, we'll come to it shortly. So how do we assess exocrine pancreatic insufficiency? There are various tests to assess how bad the pancreas is affected. We'll come to it in a tabulated manner later. But let me tell you, fecal fat estimation and fecal elastase estimation are the key to determine if there is an exocrine pancreatic insufficiency or not. Now, there are crude methods of estimating fecal fat. So how do you do that? So either we see whether there are 20 globules or per high power field under the microscope in stool sample. That is one very crude way of assessing fecal fat. The better way and a more expensive way, though it is now easily and readily available in most laboratories, is to do a fecal elastase 1. Fecal elastase 1 is a stool test. It's a point of care kind of a testing. A single stool sample is required, not cumbersome, and this testing is measured per gram of feces. So anything less than 15 microgram of fecal elastase 1 per gram of feces is highly sensitive and specific that there is a significant exocrine insufficiency of the pancreas. A range of 15 to 200 microgram per gram is less sensitive and specific. That is to say, less than 200 then is less sensitive and specific, but less than 15 is highly sensitive and specific for exocrine pancreatic insufficiency. More than 200 microgram per gram of fecal elastase 1 is almost ruling out exocrine pancreatic insufficiency. This fecal elastase is not affected by any enzyme replacement therapy that we give. That is, when we supplement a child with chronic pancreatitis with pancreatic enzyme replacement therapy, abbreviated as PERT, this particular PERT contains a lot of enzymes, lipase and trypsin. These enzymes are there, but these are of porcine origin. That is, they come from pig. So estimation of fecal elastase 1 in a human does not get impaired by this PERT. There's another method of estimation which is the gold standard, which is a 72-hour quantitative estimation of fecal fat. It's a very cumbersome procedure, and now it's often been substituted with fecal elastase 1. There are other methods like estimating fecal chymotrypsinogen and doing serum pancreatic enzymes. Serum pancreatic enzymes are a poor modality except serum trypsinogen, which can be done in the blood with less than 20 nanogram per ml, being highly sensitive for pancreatic steatorrhea. Now, what happens when there is an endocrine insufficiency in pancreatitis? Now, this is the structure, suppose, of pancreas, and let's divide it into head, body and tail. So this part is largely exocrine. This part is largely endocrine. This has the islets of Langerhans and the beta cells, which are responsible for secretion of insulin. Now, any damage in the tail of pancreas can lead to a rapid endocrine insufficiency, which is often called a type 3C pancreatogenic diabetes. This also happens post-surgery for chronic pancreatitis when a distal pancreatectomy or a subtotal pancreatectomy is done. In this particular diabetes, there is a brittle fluctuation. There are severe fluctuations between hyper and hypoglycemia, which is one of the cause of concerns whenever a patient with chronic pancreatitis comes with fluctuating sugars or altered sleep-wake cycle or a high lethargy component. Then we should definitely estimate his random blood sugars and look at if he has pancreatogenic diabetes. What are the other complications I earlier mentioned? Biliary obstruction. Now the pancreas is almost embedded into the duodenum in the second wall, and the biliary duct crosses and has an intrapancreatic part. Whenever there is an inflammation in the head of the pancreas, this bile duct may get compressed, the duodenum may get inflamed, the wall of the duodenum which is adjacent to the pancreas. This can cause a duodenal obstruction. This can cause a biliary duct obstruction. This happens more often with adults, especially in patients who have either a malignancy in the second part of the duodenum or malignancy in the head of the pancreas. Now, gastrointestinal bleeding. Now, this happens because the pancreatic bed has its own arteries, especially the splenic artery, which courses very close to the body and tail of the pancreas. Whenever there is inflammation in the body and tail of pancreas, this splenic artery is encased because of the inflammation. The wall of the artery weakens and there is a pseudoaneurysm which forms within the artery, and this aneurysm may rupture, causing a gastrointestinal bleed or an internal bleed within the cavity. Now, pseudocyst of the pancreas is another complication which happens when there is a leak of the pancreatic duct. We'll come to that later, but there is a leak because of the pancreatic duct, either because of trauma or repeated inflammation, and there is a collection which is walled off, this collection surrounding the pancreas, which is called a peripancreatic fluid collection. Now, these collections, especially in adults, we need to rule out if there is a cystic neoplasm of the pancreas. In children, it is very rare. We should often take the history of any carcinoma of pancreas in these children.